Assalamu alaikum, everyone. Uh, my name is Dr. Hassan Farooq and Beats Urology Core Urology Lecture Series. Today, my topic of presentation is vesicoureteral reflux, and objective of my presentation is anatomy of VUR, diagnosis, and management. Definition: retrograde flow of urine from bladder to upper urinary tract. It has two types: primary VUR and secondary VUR. Pathogenesis of VUR, the ureter normally is attached to the bladder in an oblique direction, perforating the bladder mucosa muscle laterally and proceeding between the bladder mucosa and retrosal muscle, creating a flap wall mechanism that prevents reflux. Reflux occurs when the submucosal tunnel between the mucosa and retrosal muscle is short or absent. Primary VUR anatomy, flap wall mechanism, intramural and submucosal portion of the distal ureter are compressed against the backing of the retrosal muscle by the pressure of urine within the bladder. Paquin discovered 5 and 1 ratio of tunnel length to ureteral diameter in non-reflexing UVGs and versus 1.4 and 1 in reflexing UVGs, ureter vesical junction. Embryology of VUG ureteric buds arise from the distal most segment of the mesonephric ducts and interaction with the metanephric mesenchyme to form kidneys. Embryology of VUR ureteric buds reaching early to urogenital sinus leads to high and lateral ureteric orifice, which leads to short intramural length and which cause reflux. Also evident as reflux and lower moiety of duplex kidney, Wegener in this incomplete ureteral duplications, ureter which comes from the upper moiety lies caudally and more medially, and the ureter from the lower moiety is cranially and a short length and laterally placed. So in duplex kidneys, most commonly reflux in the lower moiety. Secondary VUR associated with abnormal bladder function and high intravesical pressure. Normal reflux mechanism of the wall is overhead. Secondary VUR it increased in intracranial pressure caused by bladder, neurogenic and non-neurogenic. Uh, Secondary VUR caused by outlet obstruction with mechanical posterior urethral wall stricture or any mass. Abnormal uterovesical junctions which caused due to the diverticulum, uterocele duplication, iatrogenic. Demographics of the vesicoureteral reflux prevalence exact values are unknown as VUR may be in asymptomatic in most of the patient. 30% of children with UTI have vesicoureteral reflux and 17% without UTI have VUR. 70% of infants with UTI have VUR. Gender difference infants with the dilated system having VUR, they are 76% male. Male child with UTI in later life more likely to have reflux. 85% of the refluxing older children are females. Boys tend to have higher grades of VUR and they more likely to resolve itself. There's 10 times lower frequency of reflux in African female children. Race-associated frequency equalizes after 10 years of age. Familial predisposition of the vesicoureteral reflux: 30% of infant siblings have the VUR, and 50% of the offspring of affected parents have VUR. 100% in the identical twins. Genetics में is autosomal dominant inheritance pattern. Likely multiple genes are involved in the vesicoureteral reflux. Age more common in younger children. Incidence of reflux in patients with urinary tract infection less than 2 years have 38.6 percentage, and 2 to 6 years natural history of reflux which spontaneous resolution and contribute. Sibling screening recommendations for screening are limited by the uncertainty of potential benefit. Asymptomatic siblings may be better served by non-invasive screening first. American Urological Association recommendations evaluate for VUR with a widening cystoureterogram or radionuclide cystogram if abnormal ultrasound or UTI. European Urological Association inform parents of children with VUR about high prevalence in siblings and offsprings. Have strong strength. Use ultrasound for screening. Have strong strength. Use use of widening cystoureterogram if abnormal ultrasound or UTI have weak strength. Do not screen older toilet trained children have weak strength. Who should be evaluated for VUR? Patients with urinary tract infections. American Academy of Pediatrics in 2016 ultrasound in children less than 1 year with first febrile UTI and video cystometry after second febrile UTI or abnormal ultrasound. Nice recommendation as the age less than 6 months if recurrent or atypical UTI and 6 months to 3 years family history of VUR, non-E. coli infection, poor urine flow or if dilatation or ultrasound and more than 3 years not recommended. With antenatal hydronephrosis, American Urological Association 2017, widening cystoureterogram is recommended for children with high grade 3 and 4 hydroureter or an abnormal bladder on ultrasound or who develop a urinary tract infection observation. European infants diagnosed with prenatal hydronephrosis become symptomatic with UTI. And infant ultrasound findings of bilateral high-grade hydronephrosis, duplex kidneys with hydronephrosis, uterocele, and abnormal bladders. They should be evaluated for VUR. And investigations video cystometrogram is a fluoroscopic study, provides functional dynamics and structural anatomy of the urinary tract, bladder filling via urethral catheterization at a maximum height of 100 centimeters from table. It also checks the bladder capacity and static images, bladder contour, presence of diverticula or uterocele, passive reflux, volume at which reflux occurs, grade of reflux, configuration and blunting of calyces and intrarenal reflux if present. Widening images में active reflux, it shows active reflux, bladder neck anatomy, funneling or dilatation and urethral patency. Post-wide film upper tracts clearance, presence of a concomitant UPG obstruction, UPGO. Reflux during bladder filling or passive reflux is considered poor prognostic sign for reflux resolution. Nuclear cystogram is a less radiation than CUG and a less anatomic detail classification into low grades. Low grade means grade 2 and grade 3 and high grade reflux only grade 4 and 5. Grade 1 can be missed due to bladder activity. Its limitations have led some to use PCMG as initial diagnostic modality and radionuclide cystogram for follow-up and monitoring purposes. VUR grades, International Reflux Grading System, is divided into 5 grades. Grade 1 into a non-dilated ureter, contrast is the ureter without dilatation. Grade 2 contrast into the pelvis and calyces without dilatation. Grade 3 mild to moderate dilatation of the ureter, renal pelvis and calyces with minimal blunting of the furnace. Grade 4 moderate ureteral toxicity and dilatation of the pelvis and calyces. Grade 5 gross dilatation of the ureter, pelvis and calyces, loss of papillary impressions and ureteral toxicity. You show the VCU findings in figure A on the right side, the contrast into the right ureter without non-dilated. It shows the grade 1 and on left side contrast into the pelvis without dilatation and it is a grade 2 and picture B on the right side contrast to the mildly dilated ureter and mild pelvic acid dilatation, grade 3. And on the left side, moderately dilated ureter and mildly tarsal ureter, and moderate pelvic acid dilatation, grade 3. And picture C, in which grossly dilated ureter and the pelvic system and loss of the nasal pili, and grossly tarsal ureter, it was a grade 5. International Reflux Committee values the spontaneous resolution of the grades. Grade 1 with spontaneous resolution at 90%, and grade 2 it is 80%, grade 3 50%, and grade 4 20%, grade 5 less than 10%. It is spontaneous resolution. Other imaging में renal ultrasound unable to diagnose reflux, no correlation between normal ultrasound and absence of reflux. Clinically significant, you are maybe missed. In the, to treat or not, in which conditions VUR should be treated. VUR is not a cause of UTI. VUR facilitates pyelonephritis, which leads to renal scarring and stunted renal growth. Higher grades associated with greater scarring. 10 to 20% with reflux nephropathy develop hypertension and end-stage renal disease. Risk of renal scarring is inversely proportional to the age. Greatest risk of post-infection scarring is during first year of life, and patients less than 4 years are more prone to scarring after single febrile UTI than older kids. Reflux associated renal dysplasia. VUR not only facilitates infection associated new renal scarring, but also congenital renal dysplasia such as smaller shrunken kidneys at birth. Abnormal origin of ureteric bud interacts abnormally with the metanephric blastema, which leads to the dysplasia. Dysplasia can look like acquired scarring. Differentiating the two can be difficult. Goals of VUR management to prevent the occurrence of febrile UTI and prevent scarring and prevent treatment and follow-up morbidity. Family and patient education. American Urological Association has standard family and patient education regarding VUR should include a discussion of the rationale for treating VUR, the potential consequences of untreated VUR, the equivalency of certain treatment approaches, assessment of likely adherence with the care plan, determination of parental concerns, and accommodation of parental preferences when treatment choices after a similar risk benefit balance. In this, American Urological Association says that family should be consulted and all the prevention of the treatment should be consulted to the family. Risk factors for VUR reflux. Gender, male have low risk, female have high risk. Age over 5 years have low risk, under 1 year have high risk. Race, Afro American people have low risk and Caucasian have high risk. Laterality, if uter is VUR is unilateral, have low risk, bilateral high risk. Grade 1 to 2 have low risk, grade 3, 4 and 5 have high risk. Bladder bowel dysfunction, if present, have low risk, if high risk, if not present, have low risk of VUR. Scars have low.
1 minute. These risk factors are for spontaneous resolution of VUR. If you find these risk factors categorized in low risk, there is more chance of the VUR to resolve spontaneously over the course of next few years. But if there are any of the high risk features are present, it is less likely to resolve itself. Please continue.
Treatment, observation, medical management, surgery, ureter reimplantation, endoscopic surgery, and a substance is injected into the area where the ureter meets the bladder to prevent backward flow of urine. It is called deflux. Medical management, antibiotic prophylaxis, a first line treatment, keep urine sterile while waiting for VUR to resolve. Sterile VUR is benign and suggested on high rate of reflux resolution. Antibiotic prophylaxis recommendations, AUA, VUR is less than 1 year of age and history of febrile UTI, continue antibiotic prophylaxis. If no history of febrile UTI, continue antibiotic prophylaxis. VUR is grade 3, 4, and 5. VUR more than 1 year of age, if bladder bowel dysfunction present, treat bladder bowel function first, dysfunction first. Bladder bowel dysfunction with the febrile UTI or cortical abnormalities, then give continuous antibiotic prophylaxis. If no bladder bowel dysfunction and recurrent febrile UTI or cortical abnormalities, continuous antibiotic prophylaxis is optional. Initial management, identifying and treating bladder bowel dysfunction. Bladder bowel dysfunction symptoms should be sought in the initial evaluation, and urinary urgency, frequency, prolonged voiding interval, perineal or penile pain, holding maneuvers, daytime wetting, dribbling, constipation, and acopris. Bladder bowel dysfunction is associated with poor VUR outcome and higher incidence of UTI on antibiotic prophylaxis, less VUR resolution after 24 months of diagnosis, and reduced success of endoscopic surgery. Minimally invasive technique which is developed in 1984, and dextroaromahyaluronic acid deflux sting procedure in which the bulking agent is injected in the subuterine position, and the hit hydrodistension implantation technique into which reflux is in the intraureteric site, and double hit most common in which double, two hit here in the intraureter. Out, Outpatient procedure efficacy 70 to 80%, risk में ureteral obstruction है, therapy failure and reoccurrence. Surgical management, absolute indications for surgical breakthrough urinary tract infection, failure of medical management and patient non-compliance, persistence of reflux with prolonged medical management, progressive deterioration in renal function, ureteral obstruction associated with VUR, refluxing ureter opening into ureter diverticulum, and cystoscopic observation of gulf hole orifice. Relative indications, presence of massive reflux grade 4 and 5, reflux associated with the paraureter diverticulum in girls whose reflux persists after they have reached the full somatic growth potential at puberty, and parental preference. The principle of surgical correction, first of all, excludes secondary reflux, adequate ureteral mobilization without tension and protection of the ureteral blood supply. A generous submucosal tunnel should be fashioned. Attention should be directed to prevent angulation and twisting. Bladder tissues must be handled gently. Attention to muscular backing of ureter to achieve effective anti-reflux mechanism, and creation of submucosal tunnel that satisfy 5:1 ratio of length. According to the approach, it has three intravesical approach, extravesical, and combined. And according to the position of the submucosal tunnel in relation to the original hiatus, suprahiatal and infrahiatal. Suprahiatal tunnel in the Puritano-Ledbetter technique, 96% success rate. Intravesical technique, the principle behind this technique, which was originally described by Puritano and Ledbetter in 1958, it is to bring the ureter in through a new hiatus superior to the original hiatus insertion. A submucosal tunnel is created in the direction of the trigone medial to the original orifice. The advantage of this technique is that a long tunnel can be created, which is valuable in the higher grades of reflux, risk hematuria and kinking. Infrahiatal Glenn Anderson technique, intravesical technique. In 1967, Glenn and Anderson described their technique of ureteral reimplantation by using the same hiatus and advancing the ureter distally toward the bladder neck. The potential complications associated with the prolyl better technique, specifically kinking of the ureter, are avoided. The distance from the hiatus to the bladder neck limits the length of the tunnel. Extravesical repair in the least Gregor is extramucosal advancement and minimal hematuria and pain, not good for dilated uterus. Thank you.